I want to welcome everyone to the Myxoid Liposarcoma Insights into a Unique Sarcoma. During this webinar, all participants will remain in listen-only mode. You'll have the opportunity to ask questions during the Q&A session at the end through the chat. Please note this information shared today is for educational purposes and should not replace the guidance from your own physician or healthcare team. My name is Tara Ruggiero, and I'm the program coordinator for the Liposarcoma Support Network, a program of the Life Raft Group. It's my pleasure to introduce our distinguished panelists from the Duke Sarcoma Center at the Duke Cancer Institute. Today's expert-led discussion will focus on myxoid liposarcoma, a rare and distinctive subtype of soft tissue sarcomas. Our panelists will share insights into pathology, surgical management, radiation therapy, and systemic treatment. I'd like to introduce our four panelists: Dr. Brigman, orthopedic surgical oncologist, director of the sarcoma program at the Duke Cancer Institute. Dr. Brigman is dedicated to providing the highest quality of orthopedic surgical care for patients with musculoskeletal tumors. We also have Dr. Riedel, medical oncologist, specializes in bone and soft tissue sarcomas. He partners closely with patients, ensuring they understand all treatment options and can make informed decisions. We have Dr. Larrier, radiation oncologist, treating both adults and children with sarcomas and other musculoskeletal conditions. Dr. Jeck, assistant professor of pathology with expertise in sarcoma and GI pathology. He works to bring advances in molecular biology into clinical practice, providing faster and more accurate diagnoses. We are honored to welcome this outstanding team from the Duke Sarcoma Center and grateful for their time and expertise today. With that, I'm delighted to turn things over to our first speaker, Dr. Brigman, who will provide an introduction to myxoid liposarcoma, including its demographics, presentation, and the role of biopsy. Here you go, Dr. Brigman.
Great. Thank you, Tara, and thank the Liposarcoma Network and Life Raft Group for putting this together. I also want to thank all the participants here. There we go. Can you all see my slides? Perfect.
Yes.
Well, again, welcome everybody. We're going to talk about myxoid liposarcoma. Most of the soft tissue sarcomas that we deal with are despite their differences in pathology, are all treated very similarly. But myxoid liposarcoma is one that is very different in many ways, that we'll come across some of those today during this discussion. Well, first of all, what is sarcoma? Sarcomas are malignant tumors. They are cancers that are different than most cancers that people are familiar with. Most cancers, lung cancer, prostate cancer, breast cancer, those are cancers of organs. Sarcomas are cancers that involve the mesenchymal tissue or the supporting tissues of the body. That means muscle, fat, bone, or fibrous tissue. They can occur anywhere in the body from the top of the scalp to the bottom of the feet, and they can occur in patients of any age. There are more than 100 different kinds of sarcoma, including sarcomas of bone, and the various types of bone sarcomas, and then soft tissue sarcomas. And again, most of the time, these soft tissue sarcomas get lumped together, but there are a myriad of different kinds. As we talk about myxoid liposarcoma, this is from a study that involved several hundred patients, and this dark blue mark here was the myxoid liposarcomas in this group. So it's a relatively small number of a relatively rare tumor, that is sarcoma. First thing I would just want to mention is that whenever you're dealing with a sarcoma, any sarcoma, treatment by a multidisciplinary team is really important. Why is that? Well, we know outcomes are better when treated by a multidisciplinary sarcoma team. That team should involve surgical oncologists, medical oncologists, radiation oncologists. Pediatric oncologists are a part of our team. Our pathologists are radiologists. And this team has to be really an integrated group. Our group meets once a week to discuss patients. Our group is very active in international meetings like the Connective Tissue Oncology Society. and it's just a great group of folks to work with, and I enjoy working with them every day. Well, we talked a little bit about sarcomas in general. What are liposarcomas? Liposarcomas are tumors that come from a fatty precursor. They can be well differentiated, or what we call an atypical lipomatous tumor, which isn't strictly a malignant tumor. They can be myxoid or round cell variants, which we're going to talk about today, pleomorphic or dedifferentiated. I'm going to show a few MRIs today, and this MRI that is on the left is what's called a T1 or a fat sensitive sequence. This is an MRI through a thigh. This little round thing in the middle is the femur bone, the bone that goes between the hip and the knee. The skin goes around the outside. Just under the skin is the normal fat that we all have. And you can see that it shows up as a bright white on this T1 image. You might also notice there's a large mass that looks very similar to that subcutaneous fat here. Now, this is a very well differentiated fatty tumor. This looks like normal fat on an MRI, and if we look at it under a microscope, it'll look very similar to normal fat. If we look at a T2 or fat suppressed MRI, which is water sensitive, the fat you'll see disappears. Now, I want you to try to remember what fat looks like on this MRI, because when we look at an MRI of a myxoid liposarcoma, it's going to be very, very different. So myxoid liposarcomas, as I mentioned, are relatively rare. There's about 600 cases in the United States every year. Most patients are aged 20 to 40, but they can certainly be younger and older than that. Like many soft tissue sarcomas, patients present with a painless mass, and that's growing in their somewhere in their body. If it's in an area like their leg or their arm, they may feel it. If it's in an area like their abdomen, they may not be able to feel that mass. The most common location is in the lower extremities. Well, people often ask, well, when should I worry about a mass? Well, if a mass is larger than 5 centimeters, that's about the size of a lime, or is rapidly growing, that's probably worth having your doctor check out. Masses that are deep to the fascia, that means not just right under the skin, are also more worrisome. And the workup that we do for these starts with a physical examination and often moves on to an MRI. Well, I showed you an MRI earlier of a fatty tumor. These are MRIs of a myxoid liposarcoma. And again, if we look on the left, we see the thigh again. You see the round bone in the middle, the skin around the outside, the normal fat underneath the skin on this T1 fat sensitive image. But you'll notice there's this dark area in the back. It's not showing up as bright white, although there are a few little areas within it, if you look very closely, that may be a little lighter than normal. When we go to the T2 fat suppressed or water sensitive imaging, you'll see it's very bright. This is characteristic of several kinds of tumors. Myxoid tumors, benign and malignant, are very bright like this. Myelin containing or nerve tumors are very bright like this, and some chondrosarcomas are very bright like this. Synovial sarcoma is another one that's very bright. And that just shows it in another plane to show how big this tumor was. So we've got a mass, we've imaged it. Now what are we going to do? Well, we can't make the diagnosis with imaging alone. We need tissue to make that diagnosis. So a biopsy is necessary to get tissue. There are some important principles that are important when one is doing a biopsy, and that this is a reason, again, to visit a sarcoma center. We need to make sure we get adequate tissue. Our goal, again, is to get an answer as to what this is. We want to minimize the complications and potential contamination of normal tissue. That contamination comes from either the needle or the incision that's made to make the biopsy. Biopsies can be done as something called a fine needle aspiration, which is often done for carcinomas. We don't typically recommend those for sarcoma for a variety of reasons. We're looking at individual cells, and for many sarcomas, it's the matrix around these cells that's helpful for that, for making that diagnosis. A core needle biopsy, like this picture that we see here of a true cut needle, is what we most commonly use, and we can use image guidance with either a CT scan or an ultrasound to help guide that needle. And then the third option is an open biopsy, where we go to the operating room and make an incision and get a piece of this. So with that, ending on biopsy, I'm going to stop my share and let Dr. Will Jeck talk about pathology.
All right, so I'll be talking a little bit about what we then see under the microscope when we look at that specimen that Dr. Brigman has taken in his clinic. I'm going to start out by just talking a little bit about the history of myxoid liposarcoma, just very briefly. This was arguably described first by the very famous father of modern pathology, Rudolf Virchow, in 1857, so over a century ago, as an entity that he called Myxoma lipomatoides malignum, which contains a lot of the same words, or at least pieces of the words, that we know as myxoid liposarcoma today. And following his initial description, the diagnosis underwent several rounds of refinement. And then this initially began by looking at different specimens under the microscope, but ultimately we entered the genomic era, and we identified a very specific pair of chromosomal aberrations. These are changes in the very chromosomes that program the cell. The T1216 and T1222 translocations that were recognized and eventually identified to lead to 2 gene fusions. And I'll talk more about what that means later, the FUS DDIT3 and EWSR1 DDIT3 fusion oncogenes. And we'll get to describing that. But first, classically, pathologists make the diagnosis by morphology. And this is the morphology that's typical of a myxoid liposarcoma. We see, instead of a fatty tumor, mostly the tumor has a very sort of pale bluish background. And this is the so-called myxoid appearance of the background that shows so brightly on that T2 MRI. And we also see here this very characteristic, extremely thin-walled vessel coursing through the lesion. And this shows areas of branching, which are also characteristic of this entity. I would say that a very experienced pathologist, on seeing a section like this under the microscope, is going to immediately have a myxoid liposarcoma very high in their differential diagnosis. In addition to that, myxoid liposarcomas have variably prominent pseudolipoblasts, and these pseudolipoblasts are shown here. We don't call them true lipoblasts any longer, because a lipoblast is a cell that gives rise to actual fat, and these are not actually fat-producing cells. They just very much look like the cells that are primitive fat-producing cells, fatty tissue-producing cells, and that's seen here. And these include these sort of white punched-out holes that indent the nucleus. In other areas, we'll see of areas in the tumor that appear to be mature fat. So over on the left-hand side of this picture, you can see some of those thin-walled vessels and myxoid background. Here to the right, or in the center, you can see these punched-out cookie-cutter holes. These are apparently fat cells. They aren't, again, true fat cells, but they have very much the same appearance under the microscope. And this is probably what gave Virchow the initial inclination to call this a lipomatous tumor. Sometimes, and very unfortunately, this tumor can show a very specific transition to a high-grade morphology, which I'm showing in this slide. These tumors are called round cell or high-grade transformation. And here the cells have become larger. They've started to become back-to-back. Each of these individual blue cells is starting to press against each other and form nests. We can still see some of this background myxoid matrix, this pale wispy blue material in the background, but now we're seeing increased cellularity. And this unfortunately portends a worse prognosis and a higher likelihood of metastatic disease. very fortunately, we don't have to rely exclusively on morphology, given the fact that this tumor, while very characteristic in its appearance, can be confused with other entities. It's very useful to know that there is a hallmark pair of changes that we might see in the very DNA of this tumor that really define what it is and how it's become a malignancy. This is an image of a cell line where they've stained each of the chromosomes with a different color. It's a cell line, so there's some things that are a little abnormal about this case that aren't present in most myxoid liposarcomas in patients. But the key one to look at is that chromosome 16, which is meant to be this brownish gray color, has now picked up some of this pink coloration coming from chromosome 12. And that indicates the 1612 translocation. The biology of this is now much better understood. What we now understand is that the DDIT3 gene, which is a gene that allows a protein to target a specific part of the patient's DNA or the cell's DNA, has been cut by some etiology, and we're still working on understanding how this happens. And the FUS oncogene has also been cut. And importantly, the FUS oncogene contains two separate process parts of the gene. One part of the gene activates the DNA to turn that part of the DNA on. And the other part that's normally attached to that targets that activating signal to specific areas of the DNA. When FUS and DDIT3 get cut and fused together to form a new oncogene, FUS loses its original targeting component and gains the new targeting component of DDIT3. And this causes these activating signals to arrive in parts of the DNA where it's not normally supposed to be activated. And this leads to the very, very specific process of tumor development that we see in myxoid liposarcoma. Diagnostically, we can use a couple of different methods to make use of this knowledge that we now have. Arguably, the most common is detecting rearrangements of DDIT3. So to do this, we put two little sort of paint, bits of paint, a green bit of paint and a red bit of paint on one part, the upstream part of DDIT3, and a green upstream and red downstream. Those two things should stay together, forming a little stoplight like we see here. And that means that the gene is still together, still functioning normally. If those two signals break apart and fly to different parts of the cell's nucleus, that means there's been a rearrangement of that gene, leading to the fusion gene that causes myxoid liposarcoma. There's other tools to identify this gene. Some institutions use immunohistochemistry, which is a process where an antibody binds to the very specific DDIT3 protein and turns those nuclei brown. So you see here that this nucleus is brown, identifying this as a myxoid or round cell liposarcoma. And the other method is actually sequencing the DNA. And occasionally we use this at Duke. If we sequence the DNA or RNA, we can actually read out the G's, T's, A's, and C's that make up the DNA sequence and identify the exact break where FUS transitions into DDIT3, something that is not supposed to be seen in a normal cell. So this is a series of methods that we as pathologists use. Once we've made the diagnosis, our job isn't necessarily over. We as pathologists answer additional questions depending on the size of the specimen we have, like, is there round cell transformation, as I mentioned earlier, which is a potentially high-grade feature? Is there treatment effect? So are we looking at a specimen that's already been treated, in which case we try to identify whether the tumor is still living or whether it's been destroyed. And then we identify features such as the margin. So if there's part of an edge to the tissue where the tissue might still be left in the patient, we try to identify whether there's tumor there and whether there's a risk of recurrence. And here I just want to end on a really nice example of treatment effect. where a tumor was present, but there's nothing left. And this is something we love to see as pathologists and actually get to see a lot of times in myxoid liposarcoma. And I hope we get to talk about that next. So I'll stop sharing.
Great. Thank you, Will. Well, so we now have a new diagnosis of myxoid liposarcoma. What do we do next for the patient? Well, for almost all soft tissue sarcomas, the staging that we do involves imaging of the chest, CT of the chest, and that's all we do. But as I mentioned earlier, myxoid liposarcoma is unique, and its pattern of metastases is unique. So myxoid liposarcoma, unlike almost every other soft tissue sarcoma, is as likely to spread to a non-lung site as it is to a lung site. These sites can include the abdomen, bone, soft tissue, really anywhere. So our staging and our surveillance is a little different for myxoid liposarcoma than almost every other soft tissue sarcoma. And a variety of different protocols are used by different folks. Some people will use a PET scan. Some people will do a CT through the abdomen and a bone scan. My preference is to use a whole body MRI along with chest imaging. And we'll hear more about these in just a few minutes. So we've staged the patient. Now there's some decision making about treatment. Well, as always, our treatment is tailored to the individual patient. But in a patient who has no evidence of metastatic disease, that is the tumor in their thigh, for example, and no evidence of disease anywhere, we typically will use a course of radiation, which Dr. Larrier will talk more about in just a few minutes, and surgery. And our goal of surgery is, again, to get all of the tumor out. Some places will use chemotherapy in this in the preoperative setting as adjuvant therapy. If there is metastatic disease, if there's tumors in other locations, then addressing that tumor in the thigh is probably not alone going to be curative. And in that case, chemotherapy moves more to the forefront, and radiation and surgery are less likely to be used. I'm going to briefly talk about surgery for sarcoma. Whenever we do any surgery for sarcoma, our goal is to remove 100% of the tumor. There's really not a role for debulking of tumor. How do we know if we get all the tumor out? Well, we try to get a margin of normal tissue around the tumor, as Dr. Jeck just mentioned. Our secondary goal is to preserve as much function as possible. And the good news is we're able to do limb-sparing resections in patients who have tumors in their limbs in the majority of cases, more than 90%, along with adjuvant radiation therapy. So I wanted to talk briefly about what a margin is. If you can imagine this picture on your screen, the white bone here is the femur, looking at it from the side. This pink area is the quadricep muscle. This is the patella here. And this green thing is a tumor, a sarcoma, a myxoid liposarcoma in this case. If we go in and just take a piece of that tumor out, this is what we've done when we've done a biopsy, and it's great for making a diagnosis, but it doesn't, it has no role in curative surgery. This is what happens, this so-called marginal resection, when many times when people do a surgery on a sarcoma, not realizing that it's a sarcoma. And this leaves microscopic disease in the leg, in the thigh in this case, and typically requires another surgery. Our goal is to do something like this, a wide resection, where we have a margin of normal muscle around the tumor. This picture is in 2 dimensions, but you can imagine in real life we're doing this in 3 dimensions. What this means is when we do a surgery on a sarcoma, our goal is to never see that sarcoma while we're operating on it. And then a fourth margin is what's called a radical resection. That is when we take out the entire compartment. And these work very well for curing people of sarcoma, but you can imagine the function with something like this is poor. Well, so what about amputation? Amputation may or may not be a good option. As I've drawn here on the right, an amputation can be intralesional, marginal, wide, or radical. But amputations do have a role when resection can't be done with drastically affecting function, or when function is better with an amputation than with a limb salvage surgery. So I'm going to stop there, and we'll move on to Dr. Larrier talking about radiation.
Hey, good morning and good afternoon, everyone. Excited to be here, and thank you all for inviting us to participate. I will be, let's see, come on. Here we go. So I'll be addressing 3 areas: radiation 101, radiation for sarcoma in general, and radiation for myxoid liposarcoma. So you've already seen our team. So let's dive right in. So when we're doing radiation therapy, the first thing we need to do is a CT simulation or a mapping session to get the patient ready for radiation. Here's a sarcoma patient who has a tumor in their leg, and we've got them in a device, which we call an alpha cradle, but there are many devices out there that we use. The next thing we do is we work on outlining the tumor volume, which is the GTV, and then we outline the area where there could be microscopic disease, the CTV, and then the PTV to allow for any daily setup error. So what you're seeing on your screen is an actual sarcoma patient, and these are the recapitulation of the volumes I just talked about. Next thing that comes is the radiation treatment planning, and we have physics staff that help us with that. And the beams are coming from all directions. You may be able to note in this particular image, we are trying to avoid the femur to decrease the risk of fracture in the future. The treatment is then delivered using a linear accelerator. Some places have options for protons, but for most patients, it's going to be photon-based linear accelerators that are used to treat these types of sarcomas. So now I'm going to make you experts in radiation for sarcoma treatment in general. So the first thing I want to do is to give you a brief history, as Dr. Jeck did. In the 1980s, folks started to think, do we really need to do amputations on everyone? Or can we do this limb salvage surgery that Dr. Brigman discussed in radiotherapy? And it was shown in a seminal study that they were equivalent in terms of the local controlling the chance of the tumor coming back. A subsequent study tried to determine if we could eliminate radiation, and in fact, we could not. Overall survival, meaning how long patients lived, was similar for patients. And so in 2000, when I got into the field, the standard of care for sarcomas greater than 5 centimeters was a limb salvage surgery, if that was feasible, and radiotherapy. A seminal study was done looking at preoperative versus postoperative radiotherapy. It was a randomized study. And as you can see, the number of patients were 88 and 94 in each arm. And it looked at wound complications at 6 months. And the important thing to note is that preoperative radiation gives a double the risk, 35% chance of wound complications compared to postoperative. Well, why do we do it? Because we can decrease the long-term side effects, so joint stiffness, fibrosis, and swelling related to this. So wound complications are higher, but the late toxicity is decreased. And whether you do preoperative or postoperative radiation, you have an excellent rate of controlling the tumor in your extremity or other part of your body. So it's a quick summary. Why does that happen? Because with preoperative radiation, we use a lower dose of radiation in a smaller radiation field. Subsequent to that, Duke was involved and participated in this study that looked at using image-guided radiation to see if we could decrease a lot of these late effects. And these are images that are taken now on pretty much any radiation machine in the country, kilovoltage imaging, and a very basic kind of CAT scan on the treatment machine. Again, it's about 86 patients getting the preoperative radiation and followed by surgery. All right. All right, sorry about that. So decreasing that CTV was what was used to make up, decrease the late effects in the study. Sorry for the background, I am at a conference. All right, and so the outcome of that study showed that we could actually decrease the toxicity rate compared to the prior study. So for modern radiotherapy, we are using preoperative radiation with image guidance to decrease the risk of long-term complications for the patient. All right. So everybody's asking us, what about immunotherapy? Dr. Riedel may discuss this, but there was a study that came out just about a year ago that looked at the use of a drug called pembrolizumab. And I brought this up because you may see out there that liposarcoma is included, but it's important to note that this is not myxoid liposarcoma. So currently, we would not be employing this medication in the upfront setting for the treatment of myxoid liposarcoma. People are also asking me when I see them, do I really have to come in every day for 5 weeks? Well, folks are looking at 5 doses, 15 doses to decrease the amount of time that folks come in every day for radiation. This is now pretty standard in breast cancer, prostate cancer, some rectal cancer regimens. And in theory, it should work better for sarcomas for some biological reasons. However, the data is not quite there. I think if we did this talk in 5 years for liposarcomas or other sarcomas in the extremity, we may be there, but the data is not quite there. So there's good news in liposarcoma with regards to radiation. There was a study done in Europe that was published in 2020. It looked at a lower dose. So instead of 25 doses, they're using 18 doses. So 50 gray versus 36 gray. And the outcome is essentially the same in terms of controlling the cancer. So that great 90% control rate that we had is similar. And the wound complications appear to be less. So this is just comparing it to the other studies that are out there and showing that they have excellent, excellent outcome in this study. So I wanted to show you one of my actual patients. So on the left, this was his preoperative MRI, and the white areas Dr. Brigman showed you was his sarcoma in his leg. And then on the right side of the screen is the post-radiation, after radiation MRI, and you can see that the tumor has actually shrunk, which is one of the wonderful things that sarcomas, like myxoid liposarcomas, can do. Someone asked in the chat about that treatment response. You can even see it on MRI, and as a patient, you will notice it. So for sarcomas in general, preoperative radiation, if it's feasible, can have fewer late effects, but at the price of more wound complications. Image-guided radiotherapy, a smaller volume, and fewer wound complications. Pre-op radiation and immunotherapy is a yes, but in limited situations currently. And for myxoid liposarcoma, we are using a lower radiation dose with excellent success. And that's all I have for you, and I will stop sharing here.
Thank you, Nicole. It's my turn. Let me first start by thanking Drs. Jeck, Larrier, and Brigman for being the appetizer. We are now at the main event, ladies and gentlemen. We're at the entree. So we're going to be talking about systemic therapy. Give me a moment to share my slides. If someone can just confirm that they can see my slides okay?
Yes.
Perfect. Thank you. All right. So over the next 10 minutes or so, I basically have 3 main objectives, and they are shown here. So I'm going to give you a general overview about how I think about systemic therapy in the management of not only myxoid liposarcoma, but sarcomas as a whole. I'll highlight some data that is publicly available that informs our current decision-making, and then I'll talk about what I think the future holds and some novel therapeutic choices. When we think about systemic therapy, just in the simplest of terms, we think about giving something into the body, for example, chemotherapy, resulting in shrinkage of a tumor that goes from something like this to something like this. The reality is it's quite a bit more complicated than that. And depending on the type of agent that's used, it can affect various parts of a cancer cell. We can affect how the cells divide. We can affect the DNA and how the DNA either unwinds or replicates itself. And so at our disposal are a number of therapies, each with differing mechanisms, which is why some therapies may work better than others. When we think about systemic therapy, we ask ourselves, what can it do? Well, certainly in an ideal situation, it can cure cancer. It can rid cancer cells from the body. And we certainly have disease states where chemotherapy is extraordinarily effective in that regard. For example, in testicular cancer, for example. It can control the cancer, maybe not make it disappear, but allow someone to live with the cancer and prevent it from spreading to other parts of the body. And certainly systemic therapy, chemotherapy included, can improve cancer-related symptoms. So all of these, I think, are things that are beneficial to our patients. The question then is, what can the cancer itself do in response to the therapy? Well, it may shrink a little, it may shrink a lot, it may disappear, it may stay the same. What we don't want it to do is grow. And so all of these options highlighted here are good options for patients, and this is not so good and what we like to avoid. As was mentioned earlier, we can give systemic therapy prior to surgery. We can give it after surgery. I will tell you that the use of therapy in that situation is controversial. We've been trying for 40 years now to show that giving systemic therapy, chemotherapy in the localized setting actually provides benefits. And the reality is the results are conflicting. If there's a benefit, it appears to be marginal. As a result, systemic therapy is largely used for patients with metastatic disease. Unfortunately, situations in which it's hard to use the word cure, but certainly systemic therapy has a potential to benefit patients despite the advanced nature of the disease. And oftentimes patients will ask, well, will it work? And I will often answer please define what work means for you, because it's different for different patients. For some patients, it means the tumor shrinks. For others, it might be it stops growing. For others, they may be focused on their quality of life and symptom improvement. Others, it may be, does it make me live longer? And so the short answer is it depends in part on what your expectation is as to whether or not a therapy will work or not. It also depends in part on the type of sarcoma, the extent of the disease, the type of therapy that's specifically being used. And so we evaluate the effectiveness, the efficacy of therapies in different ways. We will ask if it shrinks. We will ask if someone's living with the cancer not progressing. We will ask things like, are patients living without visible disease? We ask questions about quality of life. And so in an academic setting, we will publish trials highlighting the effectiveness or the efficacy of agents. And we see things like this. And I show this to you because I'm going to show you some of these plots later. And I just want you to have a basic understanding. But this is called a waterfall plot. And each one of these bars that either goes up or down represents an individual patient's tumor. If it goes above 0, the tumor is growing. If it goes below 0, it's shrinking. This dotted white line here somewhat arbitrarily sits at 30%, and anything that shrinks by at least 30% or more, we actually call a response. Things that shrink 100%, we call that a complete response. Anything less than that is partial response. And then in this range here, this is stable disease. And then way up here, these are things that are actively progressing. So I'll show you some of these later. So it's not enough to know if a cancer is shrinking. That's a good thing, but how durable is the response? And so we look at things like this, which is called a spider plot. In this case, these are tumors that are shrinking, but you can see that it's durable, in this case, over 50 weeks, that at least this individual in green had their tumor stay controlled and at a much smaller size. And then we can ask questions about whether or not chemotherapy makes people live longer. We look at things like this. This is called the Kaplan-Meier curve, and I show this to you just to know that the top line is better than the bottom line. So you always want to look at the top line there. You want them to separate, and basically individuals who are on this curve are doing better than individuals on this curve. And so again, I'll show you some of this in a little bit. When we think about sarcomas in general, we have about 6 or 7 options that we can routinely consider. This is for both myxoid liposarcomas and other soft tissue sarcomas. And we can combine agents, we can use them as single agents with varying degrees of effectiveness. Now, we've known for quite some time that myxoid liposarcoma is chemotherapy sensitive. This was a study performed back in the early 2000s. It was performed by our colleagues in London, and they went back and looked at their history of about 80 patients with myxoid liposarcoma, and they asked a very simple question: how did they do with chemotherapy? And they compared myxoid liposarcoma to other liposarcoma subtypes, and what you can see here is that the response for myxoid liposarcoma was 48%. It means among the patients that they looked at, almost half had significant shrinkage with frontline chemotherapy. That's pretty darn good. That's in contrast to some of the other liposarcomas shown here, round cell, dedifferentiated, for example, where the response rates were quite a bit less. And so we've always known that myxoid liposarcoma can respond to chemotherapy. We also know from experience that there are certain types of sarcoma that may preferentially respond to other therapies, preferentially respond to certain therapies. An example here, angiosarcoma and paclitaxel. We otherwise do not use paclitaxel in sarcoma. We use it for angiosarcoma because we've been shown response rates that are particularly encouraging. Similarly, in GIST, we will use an oral therapy that targets a protein called KIT or PDGFR. In undifferentiated pleomorphic sarcoma, we will consider immunotherapy. And importantly, in myxoid liposarcoma, we've known for quite some time that a medicine called trabectedin can be quite effective. Here are 2 studies. One on the left is from the early 2000s, 2007, showing response rates in excess of 50%. Now, we have to be careful. This was not a well-designed study. It was what's called a retrospective study. So patients looked back on their experience. When they looked at a more robust study, on the right, a phase 2 study, the response rates were above 20%. So still very encouraging. Now, the challenge is we've known this data since roughly 2007, but trabectedin wasn't approved in the United States until 2015. And that's because a lot of the data that was generated outside of the United States. And in order to get things approved in the United States, you need to have data generated within the US. And so there was a big effort made to do this in 2015. This was a large, what's called phase 3 study in which patients received either trabectedin or another chemotherapy called dacarbazine. And this study was open to all types of liposarcoma and another type of sarcoma called leiomyosarcoma. And to show you one of the curves I showed earlier, again, this is the Kaplan-Meier curve. As a general reminder, the top line is where we want to be. So for patients who got trabectedin in blue, they did better than patients who got dacarbazine. And this was for progression-free survival, so this was living with the cancer controlled. And based on this data, the FDA approved trabectedin for liposarcoma and made trabectedin now available for use in the United States. When they went and looked at what's called a subgroup analyses, and they looked at different types of liposarcoma, you can see here myxoid liposarcoma benefited. So anything to the left of this solid black line means that trabectedin was favored. And so across all of these measures that they looked at, trabectedin was better than dacarbazine. But here's myxoid liposarcoma, again, confirming the effectiveness of this therapy in this disease state, among other liposarcomas as well, and leiomyosarcomas for that matter. On the heels of trabectedin, a second agent called eribulin, which works in a different way than trabectedin, was also studied in a phase 3 study. Again, patients were assigned either eribulin or an active comparator, in this case, dacarbazine. I'll show you the Kaplan-Meier curve again. Top line is eribulin, so there's some separation compared to dacarbazine. This was now for overall survival. So eribulin made people live longer. And this resulted in FDA approval, again, for liposarcoma. And similar to what I showed you before, in a range of measures that were looked at, they all seem to favor eribulin here over dacarbazine, including liposarcoma. And in fact, a subsequent study specifically showed that all subtypes of liposarcoma, including myxoid liposarcoma, benefited from eribulin. So since 2015, we now have 2 additional agents that have been added, trabectedin and eribulin, with trabectedin now having over 15 years of experience, specifically in myxoid liposarcoma, and an agent that we will routinely consider. Well, what's new? Well, the newest thing on the block are what are called engineered T-cell therapies. And one of the things that we've learned is that certain tumors can have proteins that are unique to them on their cell surface that are not on normal cells, or if they are, they're extremely limited and restricted. And so in recognizing that we now have differential expression with some proteins on tumor cells and not on human cells, the question is, can we effectively target those proteins? So there's an emerging class of therapies called engineered T-cell therapies that are specifically designed to target these tumor, what are called antigens on the cell surface. One of them is called MAGE-A4. The other one is called NY-ESO. And while they are expressed in a variety of tumors, they are particularly expressed in 2 types of sarcoma, one of which being myxoid round cell. And the strategy is something like this. You will take an individual who has the aforementioned sarcoma. You will isolate immune cells, so you will remove some immune cells from the blood. You send it to a lab that does a series of genetic testing and engineering and basically changes these immune cells into ones that specifically target one of those targets, in this case, either NY-ESO or MAGE-A4. You then ramp them up and expand them, and then you inject them back into the person. And the idea is you're using their engineered cells to target those cells that have the abnormal proteins, in this case, preferentially the tumor cells. So seems simple, but it's actually quite a bit more complicated than that. There are some things, some hoops we have to jump through. We have to make sure that individuals have a specific blood type called the HLA genotype. It has to be a very specific type. We have to make sure that these specific proteins are expressed on the tumor cells. We then have to deplete the immune system in a person's body before we actually give them the product. And then we have to watch them for side effects. But this has been done. This has been done in the context of several clinical trials. One of them is shown here. This is called the Spearhead study. This was 52 patients. For patients who had tumors that expressed MAGE-A4. This study was for patients with synovial sarcoma and myxoid liposarcoma. And here's the waterfall plot. So I showed you earlier that things that go below 0 mean that tumors are shrinking, things above 0 are growth. And you can see among the 50+ patients, the vast majority, that's some amount of shrinkage, with over 40%, about 40%, having what's called partial response. So 37% of the patients are below this dotted black line. In fact, we had some patients that had complete response, which meant complete disappearance of tumor. Now you'll see here the response rates were higher for synovial sarcoma, a little bit lower for myxoid liposarcoma. The myxoid liposarcoma patients are the ones with the asterisks by them. So there were 8 patients. So you can see there were at least 2 here that met the criteria for being partial responses, but some other ones who had a little bit of shrinkage, just not enough to get to the threshold. Spider plot, I showed this earlier as an example. This is from the clinical trial data. So all the blue lines represent individuals who had shrinkage. And the question is, how durable was it? Well, in this case, we had a patient who had 80% shrinkage in their tumor that lasted for 176 weeks. So durable responses. And then we look at the Kaplan-Meier curve, and individuals who got responses did better. They lived longer than individuals who didn't get responses. So this is some of the data that we use to try to inform our decisions. These therapies are not without side effects. Here are some of the side effects. We have to watch for what's called cytokine release syndrome, which is basically a big sort of inflammatory rush throughout the body that can manifest itself as fever, for example, rash, as well as effects on the blood counts. But at least from this study, from this phase 2 study, which showed very, very promising response, particularly in synovial sarcoma, the FDA approved this therapy in August of 2024, specifically for synovial sarcoma. There were not enough patients with myxoid liposarcoma to result in approval, but I think what this study showed was proof of principle in that myxoid liposarcoma can be targeted for this approach. So with that in mind, the last thing I'll share with you is the most recent study called the Ignite ESO study. Same strategy. It's a T-cell product, in this case, targeting a different protein, NY-ESO, as opposed to the previous therapy, which targeted MAGE-A4. This, again, was for synovial sarcoma and myxoid liposarcoma, a very impressive waterfall plot. In this case, about a third of patients having what's called response, with probably close to 80% of patients having some amount of tumor shrinkage. I'll highlight the myxoid liposarcomas here. The response rates here, 33% had a partial response. 33% had a partial response, 10% had a complete response, complete disappearance. So quite impressive. Overall response rates across the board here on further analysis was 42%. This data is going to the FDA. I think there's a lot of enthusiasm about this, and with half the patients being synovial and half the patients being myxoid round cell, I think everyone's hope is that if this therapy gets approved, it'll be approved for both histologies, not just one. In terms of side effects, we saw similar side effects here to what was seen in the previous study. This is something that's seen across cell therapies. Again, cytokine release, rash, and then watching the blood counts here. So just in summary, I think there is a lot of excitement about what's happening in the myxoid liposarcoma space. It is a chemotherapy-sensitive histology. We have a growing number of treatment options that we can use, but there's a lot of excitement about what the future holds with some of these tumor antigen-directed cell therapies. And as always, for a rare disease, clinical trial participation is encouraged. I think we've all shown this photo. We can't do what we do without a team. And then I'll just close by thanking both the Liposarcoma Support Network as well as LifeRaft Group for allowing us to speak today. Thank you.
I want to thank all of our presenters for your insightful presentations. We really appreciate it. We'll move on to the Q&A. We had some questions in our chat, and we had some that we received ahead of time. I'll go through as many questions as time allows, and we'll see where we're at. If you have any questions, I know some have been answered also in the chat. I don't know that the people that asked the questions may have seen the responses, but other people weren't able to see the questions that were asked. So maybe we'll go through a few of those as well. We did have a question that was asked previous. It says, where do typical recurrences for myxoid liposarcoma occur?
Well, I think I covered some of that in my part. You know, myxoid liposarcoma recurrences can happen anywhere. In contradistinction to other soft tissue sarcomas where we only look at the lung. So that's why our staging and our surveillance is different for myxoid liposarcoma. So the common areas where they recur: the abdomen, bone marrow, soft tissue.
Okay, thank you. Another question we received is if you can share treatments beyond standard treatments.
So I would say that the two cellular therapies that I described, the MAGE-A4 and the NY-ESO directed therapies, are not considered standard therapies currently for myxoid liposarcoma. So those are two examples that were provided. My hope is that perhaps the more recent of the two, the NY-ESO containing therapy, I'm hoping that can result in FDA approval, but that remains to be seen.
Dr. Riedel, there are two questions in the chat, if I can chime in, that may relate to that. One is if you can make a comment on HDAC and about TILs.
So HDAC stands for histone deacetylase, and HDACs, there's about 18 to 20 of them. There's been a lot of interest over the years in looking at HDAC-directed therapy in a range of malignancy sarcomas included. I will tell you, in my opinion, the results to date have been fairly disappointing for those therapies in sarcoma, but there are ongoing efforts looking at them in combination with conventional chemotherapy or, for example, in combination with immune therapy. So I think there are still ongoing efforts, but not ready for prime time and certainly not considered a standard therapeutic approach currently. The second question, Nicole, was regarding TILs. So TILs are sort of a different immunotherapeutic approach where you are isolating what are called tumor infiltrating lymphocytes. So in theory, these are lymphocytes that can recognize the tumor as being foreign and be able to do that. They infiltrate in. There are some strategies where you can use that approach, most particularly in melanoma, where it's being used currently, again, not ready for prime time yet in sarcoma, but there's a lot of interest in looking at that approach across a range of disease state, sarcoma included, just not ready for prime time yet.
Send it back to you, Tara.
Okay. We had another question is on clinicaltrials.gov, I see many different trial options listed. How can I categorize these trials so I have a clear understanding of the types of options available for Myxoid?
Perhaps I'll just take that. So clinicaltrials.gov is a sort of a national warehouse of clinical trials that are available at institutions around the country. There are search boxes where you can search by disease state, or there's maps where you can look by state. It's in my opinion not all that user friendly. So my recommendation would be that you partner with your treating physician to help navigate some of those trials. Not all the trials that are listed are actively recruiting. Some are closed to accrual. So I think really partnering with your treating physician and or local sarcoma expert to understand the national landscape is going to be important.
Okay, thank you. All right, this is another one. It says, do you have a good up-to-date nomogram for myxoid liposarcoma after treatment? Also, how many years do you suggest follow-up scans to be done, or should it be done indefinitely?
I'll comment briefly on nomograms. There's a lot of interest in nomograms, and basically what they are using a variety of perhaps tumor and or clinical characteristics to predict risk of recurrence. Memorial Sloan Kettering has created nomograms. Our European colleagues have created nomograms. Some individuals use them, some individuals don't. I do not routinely use nomograms for soft tissue sarcomas, but I know other individuals certainly do. It depends on what information you are looking for. The second question, I'm sorry, Tara, was regarding imaging.
Hold on, let me go back to
Imaging
that.
surveillance. And so our national guidelines currently recommend that imaging surveillance be done for 3 to 6 months for the first 5 years after a diagnosis, and then annually thereafter, with surveillance being individualized after 10 years. In my practice, I will typically image every 3 to 4 months for the first 2 years. The first 2 years is when recurrence is the greatest. I will then transition to every 6-month imaging for years 3, 4, and 5, once a year from years 5 to 10, every other year from 10 to 20, and then at year 20, I may let someone graduate from my practice. Others want to comment? Brian, you
Yeah, I
want to
think
comment?
both Dr. Brigman and myself will follow folks that have not received systemic therapy along the regimen that Dr. Riedel just described.
Yeah, I do it just a little bit different. I do 3 months for the first 3 years, and then 6 months for 2 years, and then yearly thereafter. And I
as I
typically follow
think
them for their lifetime. There was a question about imaging. There's not an accepted nationwide protocol for this. So different locations do it different than others. Some people use PET scans. Some people, as I mentioned, use CTs through the chest and abdomen and bone scans. I think that whole body MRI is effective, and there's been some studies to show that. One done by Julia Viscaus, one of our surgeons here when she was in Toronto. So I typically use whole body MRI every 6 months, along with chest imaging, CT or chest X-ray every 3 months for those first 3 years. Rich, Nicole, your
sorry,
response?
I'm at a conference, everyone, so I apologize for the background. There was a question earlier on about genetic testing and genetics, and one of the reasons I personally think following folks with this disease for 2 decades is important is Some people have what's called a germline mutation, so they can be prone to having cancers. But as Dr. Brigman pointed out, the average age tends to be young. And for us in sarcoma world, young is even up to age 50. And so is there something, even if we can't find it on an official genetic test, that might make you prone to having other cancers? So I take a whole patient approach and think about other cancer screening as we go through or journey together.
There's a couple questions in the box. Perhaps I can sort of bang them out quickly. Number one, whole body MRI is currently listed in our national guidelines as something to consider specifically for surveillance of myxoid liposarcoma. That being said, it's not available at every institution, so that may or may not be a viable option. But with its inclusion in guidelines, it has become less of an insurance issue since it is listed. Number two, there was a question regarding treatment for individuals who do not have the HLA specified type, and at least currently there is not a cell therapy approach for non-HLA O2 genotypes. And then lastly, I'll just comment on the SARC-032 clinical trial that Dr. Larrier mentioned. At least in my practice, and largely because myxoid liposarcomas were not included in SARC-032, I would not recommend radiotherapy in combination with pembrolizumab for a myxoid liposarcoma, in part because they in and of themselves are so radiosensitive. So it's not clear to me that pembrolizumab would add much.
I totally agree with that. And these translocation type sarcomas that Dr. Jeck described to you, they are often not going to be responsive to those types of immunotherapies. You've heard about different kinds of immunotherapies today. So the immunotherapy that was used in SARC-032, typically we are not going to be seeing a great response anyway. But luckily, now that we found that we can use a lower dose of pre-op radiation, we don't even necessarily need to think about it. Dr. Brigman and I will find that many times by the time the patient gets to surgery after pre-op radiation, it can be difficult to even palpate or find the tumor. They've had that much shrinkage.
And I'll add that I have trouble finding it under the microscope sometimes as well, which is always a welcome finding.
All right, I think that kind of concludes our time. I want to thank everyone for attending. Thank you to our panelists, Dr. Brigman, Dr. Riedel, Dr. Larrier, Dr. Jeck, for sharing your expertise. And on behalf of the Liposarcoma Support Network and the Life Raft Group, we appreciate your participation and look forward to connecting with you in the future. And have a great day, everyone. Thank you.
Thank you all.
Thank you.
Thank you.